This is Dr. Marnie Peterson. I am the Outreach Coordinator for the Antimicrobial Stewardship Project, which was launched this year by the Center for Infectious Disease Research and Policy at the University of Minnesota. It's my pleasure to welcome all of our participants, which we currently have 36 online and 100 were registered, so we have up to 100 participants today, to today's webinar, Real-World Experiences for Addressing the 2017 Antimicrobial Stewardship Mandates, with our expert panelists, Dr. Deborah Goff, Dr. John Rotschafer, and Dr. Thomas Feil. Dr. Deborah Goff is a clinical associate professor in the College of Pharmacy, an infectious disease specialist and founding member of the Antimicrobial Stewardship Program at The Ohio State University Wexner Medical Center. Dr. John Rotschafer is a professor and infectious disease specialist at the College of Pharmacy, University of Minnesota. And Dr. Thomas Feil is Chief of the Infectious Disease Service and Director of HIV Research at Summa Health System in Akron, Ohio, and Professor of Internal Medicine and Head of Infectious Disease Section at the Northeastern Ohio University College of Medicine in Rootstown, Ohio. All three of our panelists are highly accomplished and are internationally recognized experts in infectious diseases and antimicrobial stewardship. Collectively, they have published over 500 manuscripts, contributed to numerous books and chapters, and have developed technology applications focusing on the treatment of infectious diseases, antibiotic resistance, and antimicrobial stewardship. Our agenda for today's webinar is a brief overview of the Joint Commission requirements for new antimicrobial stewardship standards that will be presented by Dr. Goff. This will be followed by a series of questions and commentary by our panelists to address the real-world challenges for meeting these standards. At any time, you're welcome to submit questions and comments in writing via the WebEx chat box located at the bottom right corner of your screen. When typing in the question, you can either send the question to all panelists to keep your questions just for the panelists, or you can send it to all participants if you'd like to share your questions with your fellow participants. Please be aware that all the lines are muted during the webinar, so you will not be able to ask a verbal question during the webinar. At this time, then, I would like to invite Dr. Goff to begin our webinar.
Thank you, Marnie, and I welcome everyone that is online and for those that will be joining us in a few minutes. So we're going to talk about the real-world experiences addressing the 2017 Antimicrobial Stewardship Mandate. And I'm sure many of you have read them, but there are 8 required standards. And I think what's important is when we look at antibiotic stewardship can optimize the treatment of infections and reduce adverse events associated with antibiotic use. There is no single template for a program to optimize antibiotic prescribing in hospitals. And I really want to emphasize that because the 3 of us today that are going to share our real-world experience are going to share what's worked and hasn't worked in our own institutions. And our goal is really to have this be an interactive discussion because we all can learn from each other. And I always look to gather ideas that work from other people. And so that's really what we want this to be, is a way to learn from our experience, but we want you to be able to share successes or failures in your program so we learn from each other. If you have not obtained the 8 standards, you can download them in a PDF from the Centers for Disease Control, Core Elements for Stewardship, and there is a link. So the Joint Commission requirements are also available online, and you'll see the key to some of the symbols that they utilize throughout the 8 core measures. So we're going to go through these rather quickly because we want to focus on really getting to how do you do this in a hospital setting as time is ticking away. January 1 will be here before we know it. So let's just look exactly what are the new 8 standards. So if you look at the first one, elements of performance, leaders establish a stewardship program as an organizational priority. We did survey on the CIDRAP ASP website a polling of how well are hospitals able to implement this and which things are considered most difficult to implement. So if we look at the response that many of you gave, The most difficult was actually implementing and establishing accountability. And I think that is a big challenge. Obviously, if people don't understand the why behind the program, it's hard to engage them in the program. So lack of interest was identified by many of you that answered the survey. And again, if you don't understand why you need stewardship, your perception is it's just being forced on you, it's very hard to engage those clinicians. And we do want to spend some time addressing how you can engage people. When you look at number 2, the hospital educates its staff and practitioners on the ordering, dispensing, administration, and monitoring of resistance and stewardship practices, and this has to be done upon hire or granting privileges. Education was viewed by our survey responses as the 4th most difficult thing to accomplish. Third, the hospital educates patients and their families. So that's even another level of complexity, is how do you convey this to patients and their family members? So we'll discuss that. The 4th criteria is the hospital has a stewardship multidisciplinary team that includes the following members when available: an infectious disease trained physician, an infection preventionist, a pharmacist, and a practitioner. So we all know that there are not enough infectious disease physicians or pharmacists trained in the United States to cover all sites in all hospitals. So how do we work around that? But this was actually the one area that most people felt they were able to comply without too much difficulty. I think generally speaking, we can find someone that's willing to lead the program. They may not be ID trained, but that doesn't mean it will not work. There's many examples where it still is quite successful. Then the 5th one is the hospital's stewardship program includes these core elements, and these are on the CDC's website. You have a leadership commitment. That is key to the program. Notice they say dedicated, necessary human, financial, and information technology resources. And there lies the challenge is, can you get leadership to fund the necessary personnel to successfully lead a stewardship program? Accountability, appointing a single leader responsible for the program, and that was identified as the 4th challenge, is accepting accountability for that program. Simply appointing a person to lead stewardship does not make them a leader. So there's a lot of challenges in identifying the person who needs to lead the program. You need someone with drug expertise. That's usually going to be the clinical pharmacist. And action, implementing the actions after you make policy. So that's kind of the boots on the ground. What is it, the day-to-day stewardship activities? And that was identified as the number 3 challenge by those who answered our survey. And then tracking, monitoring the stewardship program, which may include information on prescribing and resistance, but it's not limited to that. And that was viewed as the 2nd biggest challenge in a stewardship program. We all know it's very time intensive to track a lot of this data, and I think we're going to address this in the role and importance of the IT person as part of the stewardship program. And then next, reporting. This was identified as the 4th most common barrier, generating the reports that include valuable information such as antibiotic use and resistance to the relevant people. How often are you reporting back results to the physicians, nurses, and other relevant staff members? Education of the practitioners, the staff, and patients. Again, this was referred to a little bit earlier. How do you make this happen in your hospital? The 6th step is the stewardship program uses organization-approved multidisciplinary protocols. So they list several examples. So these are not required. They're just giving you suggestions of examples of protocols, such as an antibiotic formulary restriction. We like to use the word a protected list of antibiotics, not a restricted list of antibiotics. Just that little subtle change in wording seems to gather some interest in the program and not so restricted in telling people what to do and what they can and can't use. Assessment of different disease states, the appropriateness of the antibiotics used in community-acquired pneumonia, appropriateness used in skin and soft tissue infections. Again, these are just examples that they're sharing as effective ways to meet this number 6 step, development of care of patient with C. diff. So again, not required, but these are very useful ways to start your stewardship program. And then number 7 is the hospital collects, analyzes, and reports data on its stewardship program. So this, again, was noted as one of the 4th most common challenges in a stewardship program, because this is the part that's very labor intensive. And if you don't have a good IT component, someone's manually collecting this, which is just a time labor intensive nightmare. So IT, again, becomes quite important. And then the last step is the hospital takes action on improvement opportunities identified in the stewardship program. So that can be, as your program progresses, do you continue to identify opportunities for improvement? So a more mature program might take on the role of rapid diagnostic tests, or how do you approach penicillin allergy in your hospital? There's been some great articles on that recently, but that's probably not the step 1 for a new program. But the expectation is you don't just do a few things right up front and call it a day. Step number 8 is leaving us accountable for continuing an improvement, which should always be the goal of any program. Once you meet some of the early goals, then you tackle some of the more difficult problems that might require expertise and some first-time early achievements to be able to move on to some of the more difficult ones. So with that rundown of the 8 requirements, let's get really to the real-world experience. We're now in countdown to 2017. We're weeks away from these mandates starting. So let's start the stewardship conversation. We know what the mandates are, but what are the mandates versus reality? I think the interest in our discussion today is trying to address the reality. You know, we're not going to get 10 new people to do this in our hospital. So how does your hospital become compliant if you don't have people dedicated at this point? Who is the boots on the ground person doing the day-to-day stewardship, not setting the policy, but actually making the phone calls, talking to the clinicians, and making the interventions that are all being tracked? So what are some examples of success? So audience, we want you to send us your questions. This is for you. We're going to share some of our successes, some of our failures, and some of our recommendations as 3 that have experience in this area for more than a short time period, a fairly long amount of time period. But we do want to take your questions to be able to have this interactive discussion today. So let's go to some of our first questions that we as a committee have seen these challenges in all hospitals. And so, John, I'm going to start with you. As stewardship, a multidisciplinary team can include the ID physician, the infection preventionist, a pharmacist, and practitioners, but it really does depend on the setting. So, John, what if there isn't an ID-trained physician or pharmacist on staff? What is a hospital supposed to do? And if you don't have that training, can you share with the audience some type of training program that physicians and pharmacists can participate in to get up to speed on this?
Okay, I hope everyone can hear me. I realize that some of you are coming from the standpoint of starting a program. Some of you have probably had a program in place for a long period of time. And before I address the questions that Deb put to me, I really want to emphasize that if you're starting a program right now, to be able to carry out these 8 items that Deb talked about, giving some real thought to how you organize your stewardship program within the institution's organization, getting a formally vested group of people together that have been charged appropriately by the hospital administration to carry out this is vitally important. And then you probably also want to think about a reporting line about if you're going to make stewardship a subcommittee of your pharmacy and therapeutics committee, and that pharmacy and therapeutics committee will report to patient care, which will report to MedExec, which will report to hospital administration. this really positions you to carry out some of the things that you need to do. And there's always a need to get data. And how do you get that data? Well, you've got the workhorses in place to make it possible for you to call upon this group or call upon that group, and they will have to respond to you. In terms of forming the team, you're absolutely right. Not everybody's going to have an ID physician. Not everybody's going to have an ID-trained pharmacist. There are certificate programs that are out there. Mike Ryback's MAD ID group offers one. SIDP offers a stewardship program. There are PGY2s in infectious diseases and antibiotic stewardship. There are infectious disease postdoctoral fellowships that are out there that people can participate in, but the manpower there or the woman power there is not enough to meet the needs. So we're going to have to convert people. We're going to have to find critical care physicians or interested internists that are willing to participate in antibiotic stewardship efforts, and then we're going to have to form our hospital team. And I think our hospital team, if you can, you have an ID-trained pharmacist, or you have someone that's interested in antibiotic stewardship that may be willing to take on the training down the road. If you don't have the ID-trained physician, again, you may just have to find an interested critical care physician, an interested internist, interested surgeon might be willing to take on this. I think your antibiotic stewardship committee should include a hospital administrator, an infection control person, as Deb mentioned. We have on ours our pharmacy and therapeutics committee chairperson. We have the director of pharmacy. We have the chief microbiologist, and we have an information systems or IT person, because you're going to need data, and you need data in a timely way. And the way that you can go about this is organizing your team so you've got the key people, the key contacts that you need to deal with, and they understand that administration is charging you to carry this out. So it becomes a priority for them to get you the information that you need on antibiotic resistance for all your microorganisms for last year, and then the next year, and the next year, or to get you the cost data or the defined daily dose data, whatever you're going to be generating as your part of your annual report. If you organize this properly, I think your tasks of trying to carry out some of these responsibilities will be optimized. And I'll just stop there.
Hey, John, I'll just chime in on a couple additional programs that I've come across. So you said for training, MAD-ID and SIDP, Society of Infectious Disease Pharmacists, they both have online courses that people can take at their leisure. In addition, California has two programs. Stanford University has an online stewardship initiative that is free, and they have the antibiotic timeout program that you can take. The CDC is a partner with them. And then California, as stewardship has been mandated there for a couple years now, they have a weekend training course for clinicians involved in stewardship. And then up and coming, Shea has a training program taking place soon. Actually might be this week. And then ID Week, there was a one-day workshop. So those are annual programs. But there's one other avenue. Our colleagues over in the UK have an online free course that anyone can sign up for. And it's chaired by the British Society of Antimicrobial Agents and Chemotherapy Group, the BSAC group. And we just co-authored a paper in Lancet ID that has a table with all of the global ways you can be trained, some with fees and some that are free, that I would encourage people to go and look at that table. As I know we have some international colleagues listening in today, and you can see the various types of stewardship training opportunities worldwide. So again, that just got published in Lancet ID, and if you want to take a look at the table in there, I think all the training programs to date that are available are listed there, because that is one of the challenges, no matter who's going to be in charge. If you're not ID trained, you might need some specific training to help you, and those are some great programs that can assist in that. All right, if there aren't any additional comments, John, I think we'll move on to question 2. And let's see. So accountability. Appointment of a leader, an antibiotic champion responsible for the program outcome can be a challenge. Who is the best healthcare provider to lead the program, and what type of financial support is available? Meaning, what is the leadership commitment to put some money behind the program? So, Tom, if your microphone is working, I know you were having some challenges. Are you online to be able to answer this?
Yes, I am, Deb, although not with my microphone, but we're able to do this with the logistic use of the telephone. So I hope you can hear me.
I can hear you. Sometimes that old technology works just fine.
Good. I just wanted to comment also on the prior question regarding the Antimicrobial Stewardship Multidisciplinary Team, because what we found also is to have on the team when you meet periodically, it doesn't even have to be that often, but just to have a clinician on there who represents the sort of the practitioners to whom you're giving recommendations, just so that you can get some feedback of how communication is occurring and how they perceive of the benefit, because I think that's been pretty helpful. And then secondly, they have a nurse. I mean, we've really found, as we've been doing our comprehensive antimicrobial stewardship program, is that the nurses become quite involved, and they understand the importance of antimicrobial stewardship as well. And I've been very impressed with some of the nurses actually becoming champions of antimicrobial stewardship. So I think that's been, at least from my perspective, sort of an unanticipated positive aspect of our team. And I also want to say, before I answer your question specifically, Debbie, is, I've been involved in the clinical practice of infectious disease now for 41 years, at least if you include my fellowship time. And I have to say that the last 10 years or so that I've been involved in what I consider to be a fairly comprehensive antimicrobial stewardship program here at our institution, I've really found this to probably be one of the most gratifying experiences I've had during my career, because I really think that we've been able to provide better patient outcomes, and we've been able to show that in a variety of studies in which we've evaluated the impact of our program. But anyway, getting back to your question about, the appointment of a single leader and how do you decide on that, well, I think you really have to look at who is a true champion of antimicrobial stewardship. Now, obviously, if you have ID physicians on staff, you would assume that one of those, he or she, would take the lead on this, such as I have at our institution. But as John said, you might not have a full-time ID group or even one physician on your institution. So you have to evaluate who might be available. Sometimes you might have, a group of ID physicians who come to the hospital periodically, but are not necessarily full-time at the institution. Now, they can perhaps provide the leadership that is required. But as John also said, you might not even have that. So you've got to look at someone else who really is a leader, who is well respected in the institution, that has a significant, involvement and interest in antimicrobial stewardship. And so you have to find out who that might be in your institution. There might be a hospitalist. There might be a critical care physician. John actually said it might be a surgeon, and there are several surgeons who are involved in antimicrobial stewardship, of which I'm aware. So I think ideally these persons who you would identify have to be very well respected. I think they have to have good communication skills. They have to be able to stand up for their principles, but yet at the same time they have to be tactful in the discussions with others. So you don't want to have a person who's sort of over rambunctious or is somewhat biased in the way in which they communicate, so that you can have a good dialogue when you give recommendations. So I think you need to look for those people in your institution who would be ideal candidates to be the person responsible for the program. Now, The other point is about this question is the leadership commitment for providing not only financial support, but also protective time for the individual. So if you have identified a pharmacist who's going to be involved, and they have some training in ID pharmacy, I think it has to be very clear that they're not going to be overwhelmed with other responsibilities. I mean, maybe it's just a 50% full-time equivalent, but yet they have to make sure that they have that time available, to prioritize what they need to do to identify all of the issues that are involved in antimicrobial stewardship. And very important, they have to be reimbursed for that. And very important for the ID clinician or the physician who is designated, whether or not they're ID trained or not. And as you and John has said, there are programs that the physicians or even the pharmacist obviously can access that would be helpful in providing training that would allow them to be very good stewards. But it's very important that the leadership of the hospital, the administrators, provide financial reimbursement for that effort if it's really going to succeed and be effective.
Thanks, Tom. Yes, and I agree. It's sort of analogous to infection control. Washing hands is not an option in the hospital. It's expected, and you need to monitor it. And you have to have people available to do that. Stewardship is no different. It's not an option anymore. And the people running the program need to be compensated, or you're going to get what you pay for. That's always a good thing to share with the hospital administration. What do you get for free? Usually not top quality. So it's not an option. It's a responsibility, and it's required. All right, let's move on to the next question, which I think I'll try to tackle, is the implementation. How do we implement a program once the team's identified? How are you going to educate and obtain support from your prescribers? How do we use electronic medical records to support the implementation and change in the practices? So I think what I've learned is you'll never get support when you try to implement if the clinician, the end user, doesn't understand the why. Because what we're really trying to do in requiring stewardship programs is we're trying to change behavior, the behavior of prescribing antibiotics just in case there's infection. And it's very hard to unravel a 20-year habit of doing something if you can't really verbalize why I'm asking you to change your behavior. And I think that's the biggest challenge in getting stewardship up and running successfully. People just see it as a bunch of rules being told that they have to do this, they have to do that, and it's viewed in many places as the cost savings program. And yes, we all have fiscal responsibilities, but it is not, as you notice, amongst these 8 steps. But we all have to practice in a cost-conscious way. But sometimes, I always say antibiotic resistance is going to cost you more. Every study tells you that because you generally have to use 2 antibiotics, not 1. So I think step 1 in the implementation is you've got to find a way to get buy-in. I like to kind of use the surgeons as an example because sometimes they're the more challenging ones to work with, rather set in their ways. But you know what? They prescribe about 50% of the antibiotics in my hospital. So I absolutely need them on board. So the first step in implementing it is making sure they're at the table when you're trying to decide how to set up the program. If they feel they're a part of it, your compliance and buy-in will be far greater. But I want to listen to them. Tell me why you do this. And we're going to be recommending a change. And then the best way to get buy-in to the program is to use your own hospital data. So, if you're talking to a more senior surgeon who might have lived through the days when Cipro was susceptible to every gram-negative, including Pseudomonas and E. coli, we know in ID those days are long gone. E. coli resistance to the quinolones is upwards of 35% in some hospitals. So, I use one of the best articles I've ever found in Lancet ID that the Centers for Disease Dynamics and Economics, along with the CDC, co-authored. And there's a graph in there that shows not every, but many surgical procedures, C-section, joint replacement, cholecystectomy, you name it, colorectal surgery. And it shows a bar graph of the susceptibility to cefazolin, the number one surgical prophylaxis for most of those surgical procedures. And what happens to the surgical site infection rate and post-op mortality if you start losing susceptibility to your antibiotic prophylaxis. It's a pretty powerful graph, and it's the only graph I would show to every surgeon. The only problem with that is it's published in Lancet ID, of which I haven't found a surgeon yet that's going to read a Lancet ID article. It's not in their journals. So you have to bring it to them, and that's how you gain the support of your physician. So what's your number one concern as a surgeon? E. coli. So how's Cipro working for you these days? There's 35% resistance in our hospital. And they look at you, really? Right. And this is why we're going to be changing the role of the quinolones, the role of the carbapenems, whatever drug it is you're targeting. So once they understand why you're doing this, the practice of surgery is going to come to a screeching halt if you lose effective antibiotic prophylaxis. Well, we're pretty close to that. So it's a very powerful way to engage them. Same with oncologists. You survive your cancer, but you died of infection because you acquired a multi-drug resistant Pseudomonas in our hospital. How's that going to impact the practice of oncology? So when you find that hot button that really speaks to the end user, the oncologist, the surgeon, whatever discipline you're trying to talk to, the ICU physician, personalize it and go, we need your help because we all want to be able to use antibiotics effectively. And that is how you can implement the program with their support versus stewardship, implementing these guidelines and just sending out an email or mass communication. Here's the way we're going to do business January 1st because it's now mandated. People just don't respond well to that. So that's, I think, what I've learned over my years of not quite 41 years, Tom, a little behind you there, but it definitely works if they feel they're a part of it. And to just comment on the electronic medical records, those medical records that we've spent billions of dollars on better start doing something for us in stewardship because you can't collect all this data manually. There's not enough hours, nor have I met anyone that actually wants that job. So they've got to learn to work for you, and that's where the IT person is such an integral part of stewardship. But what I've learned is they need to be at the table when you're asking things. Sending emails to them, we would like you to do the following, generally results in, well, no, we can't do that for X amount of weeks, months, years, because they don't understand what it is you're asking them or the importance. And so if they're at the table when the decisions are getting made, could you do this? And you have a dialogue back to come to a mutual agreement of why we need this done in the electronic records and what they're able to do in a reasonable time frame. I think it works well. And one of the last comments I'll make is a great paper in Pediatric Infectious Disease Journal called Handshake Stewardship. And Tom, I think you're a great example of that. Go and meet and greet the people that you're trying to get on board. And that's exactly what this paper did. They had guidelines galore that nobody was following. So they just said, forget it, we're not going down that path anymore. It's not working. We're frustrated. We don't feel like we're making a difference. And they started making stewardship rounds. Go and just shake the hand of the person, whether that's the hospitalist, the surgeon, the intensive care physician that doesn't think they need any of your guidance, and tell them we are working together. Let's approach this in a different manner. And I know, Tom, you've succeeded tremendously in your ICU as you met a little bit of resistance early on, and you went and really did handshake stewardship, and they're your biggest advocates now.
Go ahead. Yeah, Deb, I want to just follow up on that, and I think that what your point is very well taken. I just want to give our experience. I mean, when we started our program, 8 or 10 years ago, there was resistance from some of our critical care physicians thinking that we were sort of becoming involved in the care when we're not really consulted specifically to be involved in the care. But I can tell you, after years of experience in helping them use stewardship for antimicrobial therapy, now they're amongst our strongest supporters because they realize that we've really helped them give the best antibiotics for their patients. And I think what you said earlier about knowing what your antimicrobial susceptibility is in your institution is very critical, and that's particularly important in the ICU. I mean, we periodically look at, for example, what percentage of our isolates of gram-negative bacilli are going to be susceptible to our broad-spectrum antimicrobial agents, whether that's a broad-spectrum penicillin or a broad-spectrum carbapenem or cephalosporin. And then, for example, we used to use a lot of piperacillin tazobactam, but recently, just 3 or 4 months ago, we found that only 73% of our M-negative bacilli, and that includes E. coli and Enterobacter and Klebsiella, as well as Pseudomonas, were susceptible to fifth-tazol, but yet 86% were susceptible to cefepime. So we felt, well, gosh, we should switch to cefepime as a more appropriate antimicrobial empiric therapy if we're worried about gram-negative infections in our ICU. And this has led to better outcomes. And also, as I said, our critical care physicians now come up to me and say, I feel much more comfortable when I give antibiotics now because I realize that you're going to oversee to make sure that what I'm doing is correct. And I also want to make another point, and this is sort of another unexpected positive outcome from our stewardship program, because we actually, go around, make rounds, and look at the patients, and I actually will talk to the patients and ask them about their symptoms and how they're doing. And we found, from the standpoint of satisfaction scores, that this has really provided an improvement in our satisfaction because patients now feel that they're getting a more comprehensive care because they have this other group of sort of oversight physicians and pharmacists, our stewardship team, who are overlooking their care. And so they feel a little bit more satisfied that they're getting comprehensiveness of care. So I found this to be a very satisfying condition as well.
Great. Thanks, Tom, for sharing that. All right, let's go to our next question, documenting and reporting. How do you monitor a stewardship program beyond just looking at antibiotic use, which is going to be reported as either defined daily dose per 1,000 patient days or days of therapy, and resistance patterns? And we all know that, resistance patterns are not going to change overnight. So even if you decrease your antibiotic use, you can't impact what's walking in the door if you have nursing home patients coming in with multi-drug resistant infections. So resistance can't be the marker of success. So what is it that we're reporting beyond the antibiotic use? What clinical and patient outcome data should be measured, and how are you measuring success or failure? So John, let's start with that, and then we'll move to the next part of the question. You have any comments, John, that you can share with the audience on that?
Well, I think a couple of things in terms of the prescribers. We haven't really talked about benchmarking right now, but we found that if you take a group of internists or critical care docs or surgeons, there's about a threefold variability in the amount of prescribing of antibiotics they do. And they have no idea where they are on the scale. And if you can find a way to figure out how much that individual is prescribing and link it to some outcome parameter for a particular DRG, length of stay and whatnot, and you can show them that you're the outlier, you're prescribing far more antibiotics than your colleague, and you don't get any better outcome. That becomes a real, and we've done it anonymously. We've identified, we show them the data, and then we'll tell them, here's where you are on the scale. And within a year, it's amazing how the data moves kind of into the centrist mode where the outliers all kind of start to move in towards the middle. Also, we haven't talked at all about some of the rapid testing, the rapid identification of bacteria in the bloodstream, or rapid identification of resistance. or using like procalcitonin or things like that. Physicians generally really want to do the right thing, but they don't want to be wrong. And when they're hesitant about, is this the right thing, they have a tendency to overprescribe. But if you can give them real-time data that's meaningful, I think a lot of times your task in terms of trying to get them to conform to your desired prescribing pattern becomes a lot easier.
Great. Thanks, John. So let's look at the other part of that. What do you do with prescriber outliers? So kind of the idea, if you've got someone that's not complying, how do you approach that? So I have a few ideas, but I'm going to let you go first.
There's a couple things I think you can do. And I will say we've had a couple of sit-downs with a couple of surgeons. Our chair of our Pharmacy and Therapeutics Committee sat down with some of these overprescribers and made it very clear that that's got to change. But with that said, I think there's some easier ways to go about that. If what do they say? He who holds the gold rules. Well, he or she who holds the data rules. And if you can go out and you collect data, and it's not like you're gunslinging for somebody, you're just going out there to collect the data. And if they turn out to be the outlier, and you can document that, you can generally share that information with the person on an individual basis, or if need be, you can move it up the line. You can go to their department chair. You can go to the chair of the P&T committee, and that's happened too, where our P&T chair has sat down with a group of prescribers or an individual prescriber and said, you're an outlier here. And in this day and age, we really can't allow this kind of behavior to continue. And they eventually do change their behavior. Right.
So I think some other ideas in terms of measuring success or failure, I look at an initiative we implemented down in South Africa that we published in Lancet ID with non-trained ID pharmacists. So these were really ward pharmacists, and really just looking at things as simple as time to effective therapy. Does stewardship allow you to implement therapy faster? Is the right dose prescribed, the right drug based on your guidelines, the right duration? Are cultures done, yes or no? So these are very simple metrics that any stewardship program can make significant input on and make a difference in that. Still IV to oral conversion, that's a stewardship initiative. More complex ones that we rely on our IT department to help is look at infection-related length of stay from, start of antibiotics to completion, ICU length of stay, mechanical ventilator days in patients with pneumonia. There's many different metrics, but I think time to effective therapy is one of them. And, the prescriber outliers, John, I think you really nailed it, like benchmarking them but benchmarking them to their colleagues, their own peers, is a very effective way because, one physician never knows what the other one is doing. So you start thinking what you're doing is normal until someone points it out. Actually, no, you're an outlier. And then they're like, really? Nobody else is doing this? And it definitely moves the bar and changes things. So we've got one last question that we want to cover, but I do want to answer one person's question that's come in about the Lancet ID paper that I referred to, where they show cefazolin susceptibility and all the different surgical procedures and what happens when you develop resistance to it. That was published in Lancet ID 2015. Volume 15, page 1429, and the author is Aude, A-U-D-E, Telliant, T-E-I-L-L-A-N-T. So hopefully you've got that. All right, so let's go to our last one, and then we're going to continue taking additional questions from the audience that are coming in right now. So when we look at outcomes and compliance, is stewardship a quality improvement program, or is it a cost savings program? Tom, I'm going to throw that one your way.
Okay, well, it's interesting because I think a lot perceive that antimicrobial stewardship is basically a cost savings program, and that's why the administrators are so keen to have these programs available. And while I agree that, at least initially, the antimicrobial stewardship programs are going to be definitely cost savings programs, but the overwhelming primary goal of stewardship should be quality and better care of patients. I mean, it's basically, as I consider it, a patient safety issue. I mean, if we really look at what has been the incentive to develop antimicrobial stewardship programs, in part, at least, it's been the crisis of antimicrobial resistance. Deb, you already mentioned this. I mean, antimicrobial resistance threatens much of the advances that we've seen over the past couple of decades in medicine. I mean, it threatens transplantation medicine because you could have a great transplant occurrence, but if you get a post-transplant opportunistic infection that is resistant to all the antibiotics and the patient doesn't do well, then what good is that in the transplant? It affects cancer chemotherapy that you mentioned. It affects immunologic or therapy that we give to, for example, rheumatoid arthritis patients that really has been a game changer in their life and allowed them to have a much more fulfilling life, or Crohn's patients or whatever. But yet we also know that they are more susceptible to infections, and if they get an antimicrobial resistant infection that threatens their life, well then what good has it been to provide these types of advances? So it threatens these advances. And so we know that we have to do whatever we can to reduce this antimicrobial resistance. So in part, antimicrobial stewardship program should be able to do this. So I think we have to really stress this as a quality issue for providing better outcomes for patients.
Right. Go on, John. Oh, I'm sorry. I think I lost John. Tom, I agree. Cost savings is always going to be a component, but it's a quality improvement program. And I think as you show metrics of, when you get time to effective therapy better because you're doing stewardship, patients actually improve faster when they're on the right antibiotic. That just sort of makes sense. You can actually show cost savings. We've done it here with the management of staph bacteremia. You give the right drug faster. We've shown it with Acinetobacter, Baumannii infections in our ICU units. And, that's part of our work that we've published because we have a high volume of patients, and you actually can show many significant differences in using stewardship principles with time to effective therapy. So, as a collateral benefit, we saved money, but that's not the reason we do the program. It's a quality improvement. Our goal is to improve the care of management of patients with infection. So I think, go on.
Can you hear me, Debbie?
I can hear you, Tom.
Oh, okay, good. Well, actually, I want to agree with that and also say that, as we show that there's been improvement in patient care, either with these patient relative outcomes, which may be decreased length of stay in the hospital, decreased readmission rates, more rapid resolution of morbidity or illness as we have more use of appropriate antibiotics, sometimes because of using these rapid diagnostic tests, and even sometimes decreasing mortality. As we show that to our practitioners, it reinforces, I think, their involvement or their acceptance of our recommendations, and it, I think, reduces any of the barriers, because obviously when we can show that we're helping them have better patient outcomes, that's ideal for the outcome for antimicrobial stewardship. So, for example, we noticed in our about 5-6 years ago that almost all of our patients coming into the hospital with cellulitis from the emergency room were on very broad spectrum antibiotics. I mean, such as piperacillin, tazobactam, plus vancomycin. And then when we go talk to our ED physicians, we ask, why are you doing this? Well, they said, we just want to cover everything, get them up to the floor so they're out of the ED. But we know that these patients with non-separative cellulitis, 95+%, it's just going to be a beta strep type of infection, and all they need is penicillin or some amoxicillin or sulfasalin rather than with vancomycin, we actually got them out of a hospital quicker, and we had less readmission rates, mainly because everybody was afraid about MRSA, and they were sending these patients home on oral trimethoprim sulfa, which at least I feel is not the best drug for beta strep cellulitis. I know that there's some controversy about that, but at any rate, we would send them home with amoxicillin or cephalexin, and we definitely noticed a decrease in readmission rates. And so when we start showing these metrics to our providers, it just reinforces how they accept our stewardship recommendations.
Deb, can I just add a couple things here?
Sure, John, jump in.
I think that, 15 years ago, if you got into a better buying group or you did generic substitution, dosage substitution, parental to oral switch, any number of those programs, you could save a lot of money.
Right.
The world's changed. Generic drugs are not cheap anymore. And if you look at what's coming down, we've got all these lipoglycopeptides. They're not going to be inexpensive. We've got these new beta-lactamase or cephalosporin beta-lactamase inhibitor combinations. Those are not going to be inexpensive. And so if you couch your program on the perspective of we're going to save you money, you're setting yourself up for failure.
Right. Right.
And you might as well tell the people right up front, our antibiotic costs might actually go up. But as Tom was talking about, if you look at the outcome, we may save money in the long run.
Right. And, that's where I think the IT component of stewardship is so critical because, when we're saying outcome, if you're the poor pharmacist or physician just trying to make interventions and now you've got to track all this outcome data, it is a full-time job. We need IT to find a way to be a strong component of the program to help collect all of that data, because that really is the meat of, the core aspect of proving your stewardship interventions are making a difference outside of cost savings. And you're right, we've got a monoclonal antibody now for C. diff. Right. There's no price yet, but it'll be thousands of dollars. But what a great advancement in medicine if you can actually predict who you can prevent recurrent C. diff by giving them probably a very expensive drug. But that's the art of stewardship. If you know what the cost of readmission for C. diff is, let's say the drug is $2,000 or whatever, it's not priced yet, but that might be a very wise way to spend your money to prevent a readmission. And that, to me, is what makes stewardship fun, is forecasting and projecting that based on your own hospital data. So I did want to comment on something Tom mentioned about, how, we're in just such a different era with antibiotic resistance and how everything like a transplant program can come to a screeching halt if you start losing our effective antibiotics. And I'm part of an ASHP mentoring program, and that just jumped right out at me as I was at a hospital with Dr. Karam, who's the ID physician that I do the program with, in a smaller community hospital, about 400 beds, and they had just implemented a kidney transplant program, but they were really marketing to patients from other countries. And I said, that's great. And the CEO of that hospital, I will never forget, sat there with arms crossed and said, I see no reason to have a stewardship program at my hospital. And I was like, wow, this is going to be a fun day. And they did not have profound drug resistance. Their antibiogram was our antibiogram from 20 years ago. It was very nice to look at and refreshing to know there's a few hospitals that don't have profound resistance. So having him understand why he needs stewardship was really challenging until they told us about their new kidney transplant program, of which we turned to the surgeon and said, what country is it that you're recruiting patients from? Israel. Well, anybody that knows infectious disease knows from Yehuda Carmeli's data from Israel, they have one of the most highest rates of antibiotic resistance in the world, of which we turned to the surgeon and said, so when you import extreme drug-resistant Acinetobacter, Pseudomonas, E. coli, Enterobacteriaceae, KPCs, you name it, what's it going to do to your program? He goes, that would be the demise of our program. It would shut us down. And literally that CEO turned and said, you now have my attention. So again, it's understanding, how do you personalize it? What is the hot button that's going to have a CEO understand in that rural setting that doesn't have profound drug resistance yet? Why do they need to do this besides the fact Joint Commission is requiring it? So, what do you think? Let's try to address that other comment. What happens if you fail to comply with all the standards? What do you think the consequence is going to be? Any thoughts on that?
Well, Carlos, can I speak?
Yeah.
Oh, yeah, okay. Fine. Well, Jen, I think that's a very good question. I think since this is just going to be implemented literally in about a month, I think we just don't know how Joint Commission is going to respond. And I don't even know if they know what their benchmarks are going to be for compliance. I mean, as this is just starting. And the Joint Commission reviewers, I think, it's going to be a learning curve for them as well. But I think this is going to be a great opportunity for all of us to gain better information to show the impact of antimicrobial stewardship as we go forward. But I mean, if you look at other Joint Commission criteria, oftentimes you'll get sort of a deviation or a non-compliance in certain standards, and depending upon the severity of that, it's very unlikely that you would lose your accreditation, although that has happened, obviously, in certain hospitals. Usually it gives you sort of a comparison for a contingent accreditation based on improving these types of standards. So I would assume that at least initially, there's going to be a learning curve as to how the Joint Commission observes as they evaluate these standards in each institution, because each institution is going to be different how they implement them anyway.
Great. All right, so we have two questions we're going to wrap up with. One asked, where can I find the information on some of the workshops and programs and free and programs with fees? So we published a table in an article in Lancet ID. It's early release online right now. I'm the first author, so you can find it in Lancet ID. It's global collaboration of 5 countries in stewardship. But if you look under my name, you should be able to find that. So let's conclude with a question here. Name the number one barrier you each encountered initiating your program and the strategy you took to overcome that barrier. So I'll just start. I think my number one barrier when we started this many years ago is trying to get buy-in in a 1,400-bed hospital. And honestly, the way I personally chose to overcome that barrier is go literally what I would call now, coining the term from the first author of Handshake Stewardship, was literally going around and personalizing the reason I need them on board. So went to the head of surgery. What do you think our current rate of E. coli resistance is to Cipro? Oh my gosh, it's really that high. This is why I need you on board. Can I count on you? Going to the head of pulmonary, going to the different transplant services, literally going around lobbying support. You have to sell yourself and market your program so they know and trust the steward behind the policies, and that was what I did. John and Tom, you want to comment on yours, and then we'll wrap this up.
Okay, well, this is Tom. I would just say that the greatest barrier we had, at least initially, was the reticence on part of the physician groups, particularly in a couple of our departments. And the way we resolved that, we actually went to every department, and actually all the nursing staffs as well, because I wanted to make sure that they were aware of the impact and the reason, rationale why we wanted to institute this program. But once we went to these departments and explained the rationale, gave them all of the information about resistance and how it was threatening their patients and how we feel that we're going to be able to help improve their patient metrics, then we were, and we did a lot of face-to-face communication as we would make rounds in the hospital, and eventually we were able to overcome that reticence. And right now, and we publish this, we have about a 96% compliance with all of our recommendations. So basically it was just communication, education, face-to-face discussions.
Awesome. John?
Yeah, I'd say it was the same thing, that it was the surgeons that really were unhappy with us messing with their antibiotic prescribing. And one of the things that we started to do, we generate an annual report on which antibiotics are being used in the hospital, how much of the antibiotic is being used, and what are the resistance rates. And we started sharing those charts with the physicians. In the meantime, we get involved in some of their individual cases. And we were very lucky. We started the program in 1998, and we had a quarter-time ID physician that actually the pharmacy paid for. And we actually were able to help some of the surgeons on a couple of cases, which got us a lot of credibility with them in terms of what we were offering in terms of consults. And once we started to get over some of those barriers, everything just kind of started to fall into place.
Perfect. Well, we're at the top of the hour, so we need to wrap it up. We appreciate your attendance today and questions, and we hope we can all move forward in this journey to make a difference by implementing stewardship in 2017. Thank you for your time.